Hello, good evening, everyone. And it's a great pleasure to welcome you all for this exciting session on new paradigms in the treatment and management of lung cancer. A lot of things to be discussed, and I think this agenda is being formed so nicely. So, thanks to Dr. David Arya. Uh, uh, it's a pleasure to welcome you, sir. Dr. David Arya needs no introduction. He's a director, Department of Medical Oncology at Max Healthcare Hospital, Delhi. So, good evening, Dr. Davis, sir. Over to you for your welcome introduction and setting the context, please. Over to you, sir.
Yeah, so thank you, Tarun, and a very warm good evening to everyone, all the attendees. I think lung cancer, the treatment landscape is moving, and Dr. Bhushan will remember how we were discussing in the DMG today the emerging role of different therapeutic options, and we were debating what's the role of immunotherapy along with chemotherapy in the new adjuvant setting. And I guess this is one landscape of oncology where there's a new advance happening every 2-3 months. When we talk about adjuvant targeted therapy, we are talking about adjuvant immunotherapy post surgical resection. In metastatic space, we're talking about immunomonotherapy. So I think overall, lung cancer has moved from one size fits all approach to a better molecular understanding of the disease, particularly adenocarcinoma, but also increasingly other subtypes. And increasingly, we are looking at personalized treatment. As a medical oncologist, earlier I used to rely on clinical parameters like subtype of disease, Asian origin, age, and then decide whether a patient was fit for gefitinib or lorlatinib. And within a span of a decade has changed to a situation where for different molecular markers, in fact there are 10 or 11 active molecular markers, you have 5 or 6 different drugs. So what we hope to achieve in this meeting today is discuss the role of molecular oncology and see how the treatment landscape has changed, what new is happening, and what's the evidence backing that. So thank you once again, all of you, for joining, and I really hope that we all have good takeaways from the meeting today. So I think if we are good to go, we'll start with the first but the most important session perhaps of the evening. So the session is uh, talking about the role of molecular oncology, so role of molecular biomarker testing in lung cancer. And to give that talk, we have Dr. Vikas Goswami, who's Associate Director of Medical Oncology at Max Hospital, Vaishali. So very quickly, Vikas, over to you. A very important session. Thank you.
Thank you, Dr. Devrat. Am I audible?
Yes, Vikas.
So I want sharing rights. My computer is saying that I cannot share the screen while other participant is sharing.
Now you can share, sir.
Okay. Just a second. Is my screen visible?
Yes, sir, it's visible.
Okay. So thank you, Dr. Devrat Arya, for giving me the opportunity. At the start of a session, I'll be talking about the molecular biomarker testing in lung cancer. So like Dr. Arya was mentioning that the era of histopathology reliance is getting changed into the era of molecular marker driven treatment. So I'll be discussing about what kind of marker testing we do, where do we stand. So very briefly, we know the incidence and mortality wise, lung cancer comes in the top 5 along with colorectal, stomach, prostate, stomach, and liver. And we know that the lung cancer is predominantly smoker driven cancer, and there is a male is to female preponderance of almost 4.5 to 1. And incidence wise and mortality wise, I already mentioned that it's there in the top 5 in both the sexes. So moving on to the topic, we know that lung cancer treatment cannot start without knowing what kind of molecular markers and driver mutations are there. So briefly, the most common ones which we do are EGFR, ALK, ROS, MET, KRAS, PIRA, FER2, RET. These are the basic panels which we do. And if I show you a 30,000 feet view overview of how do we treat lung cancers, there it is in front of the screen. So non-squamous versus squamous, we divide the treatments are there based upon the kind of mutation found, including the PDL1 scores. And based upon these, we divide the treatment either on oral TKIs or chemotherapy plus immunotherapy or immunotherapy alone. Testing methodology for targeting mutations. Basically, they are broadly divided into FISH, IHC, and PCR based. So for example, EGFR, we have the PCR based. For ALK, we have the FISH. For ROS, we have the FISH. For PDL1, we have the IHCs. And sometimes IHC is there as a backup method for ALK and ROS. So for the evolution of markers, historically, we all have been using tissue-based methods, but of late, we now know that we are in the era of liquid biopsy, where plasma-based methods and comprehensive genomic profiling on circulating DNA is also possible. So if I talk about EGFR driver mutation in lung cancers, the most frequent EGFR TKI sensitizing mutation occurs in exon 19 and 21. However, we also have exon 20 and exon 18. So from 18 to 21 are the targets which we have. We have some medicines for each one of them. And the sample usually is fresh, frozen, or alcohol fixed specimens, and a PCR based methods are preferred. So of course, the issue with the EGFR testing is that we need good quality of tumor tissue. We also need relative relevance expertise of the center. It's not a anybody can do that test. So there need to be specific guidelines on who and how it is to be done. So IHC or FISH for EGFR are not recommended. Sensitive testing methods are able to detect mutation in specimens with less than 10% of cancer cells. However, the problem with ultra-sensitive tests is that there are issues of false positive tests. So lab should not be able to detect all individual, should be able to detect all individual EGFR mutations that have been reported with frequency of at least 1%. Like I was mentioning, that we now are also able to do circulating DNA testing, and that role is primarily for detecting the EGFR mutation. So due to challenges with the circulating DNA, assay for detection must be highly sensitive and specific. Assays can be single gene, panel of genes, or whole genome. So, the frequency varies from population to population. In Asian, we have the data ranging from 10% to almost 60%. Most common studies have reported 30 to 40%, while in Caucasian studies, we have 10 to 20% incidence wise. And similarly, NCCN recommends EGFR testing not only for advanced stage, but also for early stage cancers, because we have the option of giving EGFR inhibition in adjuvant setting as well, starting from stage 1B to stage 3. ALK rearrangements, rearrangement in chromosome 2 causing novel fusion of oncogene EML4 ALK, predominantly in adenocarcinomas, and occur independently and exclusively of EGFR or KRAS mutations. Prevalence in India is not high, it is around 3%. And in most cases, ALK IHC is 93 to 100% sensitive and specific compared to FISH. The false positive rates are about 0.1% with FISH. IHC is also faster and easily available and cheaper. So the role of ALK RT-PCR is limited to find the predefined fusion partners, and there are high failure rates, so not widely accepted. ROS1 is another targetable mutation which we search for, and in Indian population, the incidence is even lower than ALK. It is about 1.6 to 2.3%, and it's also usually limited to adenocarcinoma. And crizotinib is a drug shown for ROS1 mutations. And FISH is relatively a straightforward and easy to interpret test. Candidate identification for large phase 1 clinical trials for crizotinib in ROS1 rearranged tumors used anchored multiplex PCR with NGS or RT-PCR. So ROS1 IHC in clinical practice is usually limited to a screening tool. Confirmation with another method is usually required. So if we see the algorithm for ROS testing, usually they recommend that if it is positive by IHC, you have to reconfirm by another method, that is the FISH method, and vice versa also. If ROS FISH is positive, they usually recommend that reconsider by a second method. It may be IHC. PDL1, the role of PDL1 in NSCLC, we all know, and possibly we're going to talk about it down the line in the later sessions in the evening. And the issue currently is that we have various kits. We have the DACO22C3 for pembrolizumab. We have DACO288 for nivolumab. We have Ventana SP263 for durvalumab and nivolumab. And we have Ventana 142 for atezo. And all of them have different cutoffs. And this is primarily based upon what kind of kit was used and what kind of cutoffs were used in the trials. So this is how they look. The darkest stains are taken by SP263, while others are relatively lighter, and each one has its own scoring system. So consideration for testing for other mutations, apart from that, EGFR, ALCROSS, PDL1, we usually search for BRAF, MET, RET, HER2/neu, KRAS, and they can be part of initial panel or they may be performed separately. BRAF is a single gene assay done by IHC. RET is usually done by all FISH, IHC, or RT-PCR, or even NGS. HER2/neu, we have three options of IHC, FISH, or NGS. KRAS is usually PCR based, and MET is IHC or FISH. So now often we use NGS testing, and all of them are encompassed. All these tests are encompassed in that one testing. However, the issue with NGS is the turnaround time. Histology based technique, the TAT is 1 week, maximum 2 weeks. However, PCR based techniques, the TAT is 2 weeks. And high throughput platforms such as NGS can be used to screen several genes at a time. That's the advantage, as against the individual testing being done by IHC based techniques. So to conclude, biomarker testing in NSCLC has evolved from single gene to multi-gene testing. Multidisciplinary meetings help in better understanding of sample and test requirements. Sample should contain adequate tumor content, at least 10%, to prevent delay in processing. Ideal TAT is 2 weeks, and high throughput platforms such as NGS can be used to screen several genes at a time to provide results within the estimated TAT. So with that, I conclude. Thank you. Over to the organizers.
Thank you, Dr. Vikas, sir. Thank you so much for just a wonderful talk. And over to Dr. Devdutt Arya, sir, for your comments.
Yeah, I think Vikas, you've very nicely covered the various parameters, the various molecular biomarkers. I know time is limited, and if we have to talk, we can talk in a greater detail and a lot of detail. But I think it was an excellent summary of how we are approaching advanced non-small cell lung cancers and the way we use these biomarkers. So thank you once again for that excellent talk. And we'll very quickly move ahead, and we have a short panel discussion. The panel discussion is about the management of EGFR mutated lung cancer, and we have a very esteemed panel in front of us. So the session is going to be moderated by Dr. Venkat Pradeep Babu Koyala, who's a senior consultant medical oncology at Assam Cancer Care Foundation, Assam. And I'll quickly also invite the panelists on his behalf. So the panelists are Dr. Shalabh Arora, who's a consultant medical oncology and hemato-oncology at Ujala Cygnus Hospital, Haldwani. We have Dr. Ankit Batra, who's an assistant professor in the Department of Medical Oncology and Hemato-Oncology and BMT, Cancer Research Institute, HIMS, Dehradun. We have Dr. Amit Sehrawat, who's assistant professor, Department of Medical Oncology, Hematology at All India Institute of Medical Sciences, Rishikesh. We have Dr. Bhushan Dumbare, consultant thoracic surgery, Max Hospital, Vaishali. And we have Dr. Javed Muzammil, who's medical oncologist at Medicare Super Specialty Hospital at Srinagar. So over to you, Dr. Venkat.
Thank you, Dr. Devarath sir. Thank you for this opportunity. I invite all my panelists. Already invited Dr. Shalabh. Are you there?
Yes, Dr. Venkat.
So all your panelists are there, sir, for the moderation. Dr. Venkat. Yeah.
I'm just.
Sir, request to please do slideshow mode.
Yeah. So at the outset, good evening to all my panelists, and thank you for giving me this opportunity to moderate with excellent panelists. Let us come to a conclusion. Although we know that osimertinib is an excellent molecule, but let us discuss how we take a clinical decisions daily for different patients with the same set of lab profile. So this is about a 54 years old gentleman who was a former smoker. He left. He previously worked in army. However, he was retired, and recently he was evaluated for the pleuritic chest pain and shortness of breath that is gradually progressing over the past month. He has a past medical comorbidities of diabetes, but even then, because he was a retired army person, he was the performance status is excellent. ECOG performance status 0. So with this history, when a patient presents to our OPD, particularly with so much of significant smoking history, what are the other steps we will take to rule out the most feared condition, that is malignancy? Dr. Shalabh Arora, how will you proceed in such instances in your setting?
So I think upfront, if this patient presents with these complaints, I would begin with imaging, and if depending on the imaging, which would or at least include a CT of the chest, I'll begin with that. And then depending on the imaging, I would like to get a tissue diagnosis, either by bronchoscopy or probably if it's a peripheral lesion, then by CT guided biopsy.
Okay. So initially we'll start with imaging. That's a very apt way to go about. Dr. Amit Sehrawat. Dr. Amit Sehrawat. Yeah, good evening. Good evening, Dr. Amit. So yeah, you are audible. So particularly when we are suspecting a patient with lung cancer, what are the past history or comorbidities you want to focus at? Because we know that this is he is a potential candidate that he may land up in diagnosis of lung cancer. So when we are taking the initial history at the presentation, what are the comorbidities which you want to focus, particularly with respect to the diagnosis and treatment of lung cancer?
So, especially in today's immuno-oncological era, we want to have a comprehensive molecular profile of such patients. So, comprehensive endocrine profile of such patients. So, other than general physical examination, performance score, what are the comorbidities patient is having, what is ejection fraction, whether patient is diabetes, diabetic, hypertensive. So, all these things actually going to help us in deciding the therapeutics, as well as while patient is on treatment, we need to monitor all those things. For example, if patient is having borderline performance score, so probably we might not be interested in offering in combination chemoimmunotherapy, or we might be a bit relaxed, like in terms of starting the initial therapy. So comprehensive general physician's point of view, general examination profile, and comorbidities evaluation. That's what we are.
Yeah. So points very well noted, Dr. Amit, because these are the very important points that we need to note at initial contact to decide upon the further treatment, even before we have molecular profile in hand. So Dr. Javed Mujamil, good evening, sir.
Unique.
Good evening,
Yes.
sir. I am good, sir. How are you?
Fine.
So we know that majority of the patients, at least many of the studies says that 15 to 20% of lung cancers, they arise from the smoking, they have the smoking related comorbidities, particularly COPD. So in your practice, what is the pattern of the patients they present with the lung cancer? Does they have significant amount of COPD, and do you routinely perform pulmonary function tests in these patients?
No, I don't routinely perform pulmonary function tests in all patients, but some of the patients in our clinical practice, they are labeled as COPD at the beginning only, because this the disease of not in young people, but it's mostly the disease that comes in beyond 50 years. That we have odd patients which are very young also. That sometimes I have seen small cell lung cancer presenting at 25 years of age. That's very uncommon. Yes, lung function tests only advised in those patients who have this out of proportion chest symptoms than that of the disease in the chest. So there I do lung function tests, and who are not labeled earlier, that they are COPD, so they have lung function tests at their disposal at the beginning of.
Yeah, very well noted. The reason which we, as you said, it is by case-to-case basis we need to decide, and in patients who are symptomatic, maybe we need to do pulmonary function tests and other investigation if necessary, so that patient and attendants will not attribute the side effects to the therapy, but we can say that we can establish a baseline truth for that patient. So as Shalabh has said, the imaging was done and CT scan, a CT of the chest has shown the left large pulmonary mass in the left upper lobe, 42 into 37, sorry, middle lobe 42 into 37 millimeters, and CT of the abdomen showed metastasis to the adrenal gland, which is one of the most common site of metastasis. Biopsy was done, which is adenocarcinoma, and because of metastasis to adrenal gland, it is labeled as stage 4 NSCLC. Dr. Bhushan,
Yes.
sir, good evening.
Good evening. Yeah.
So now medical oncologist is satisfied with CECT chest and abdomen and labeled as stage 4. If a patient upfront presents to you, do you want to advise any other investigations to know all the site of metastasis? Are you satisfied that it is stage 4 disease and will refer to medical oncologist?
Yeah. This looks like a oligometastatic disease. Okay. A centrally located mass lesion. Probably I would like to see the CECT pictures, whether this is operable or not, whether pulmonary artery or major vessel is involved or not. And one bigger thing out of all this investigation, I would do a PFT and DLC of this patient and a 2D echocardiography.
Yes, sir. Points well taken. But do you want to perform any additional imaging like PET CT?
Definitely, PET CT, whole body PET CT should be done, and also MRI brain.
Okay, sir. So MRI brain. So
Contrast enhanced MRI brain.
MRI brain. All right, sir. Dr. Ankit, will you agree to go ahead with PET CT in this patient, or are you satisfied with CECT chest and abdomen showing stage 4 disease? MRI brain, well taken. Usually majority of us perform. So Dr. Ankit, what is your take on doing PET CT in this patient?
So sir, if you have patients who have reports like lung issue and has already got a CT, in those cases, but if upfront imaging is not done, and we have the opportunity to get a PET CT, so like to get the PET CT.
Dr. Bhatta can't hear you. Can you adjust your mic, please?
Hello, can you hear me, sir, now?
Yeah.
So if there is no logistic concern and in this patient, like already CT test and abdomen has been done, and MRI also has a solution. So in these kind of cases who have already done and if there is a logistic concern, then we can avoid. But if there is no logistic concern and the patient is coming upfront, so upfront directly we could do a PET CT.
Okay. What was the practice at Cancer Institute Adyar from where you were trained? So are you doing the
Adyar, sir, like we had mandatory for all patients for lung cancer to do a PET CT.
All right. Sure. So now this patient has a histopathology of adenocarcinoma as we discussed, and the molecular panel is in our hand. it is showing that EGFR mutation and L858R mutation. So, Dr. Shalab again. Now you have molecular report with you, and it is exon 21 mutation. Anything goes on your mind? Do you have any ideas of going on in mind whether patient will have a better prognosis, or had it been DEL 19, whether if will your decision will be different to start any treatment among these options that are available as of today?
So I think if there is deletion 19 or there is L858R, I think therapeutically there won't be any change in the therapy, because we all know that both these mutations, which almost account for 90% of all EGFR positive cases, I think osimertinib single agent would be the go-to therapy, as long as patient does not have overt symptomatic CNS disease. So, and however, if there are rarer EGFR mutations, then definitely I would look at other options. For instance, if there is exon 20 insertion, then I would think of probably chemotherapy for that patient.
Okay, point well taken. But do you think the outcomes will be different if it is exon 21 or deletion 19?
The outcomes are similar for both. If we treat with EGFR TKI, the outcomes for DEL 19 and exon 21 are almost comparable.
Okay, sure. Let us take an opinion from Dr. Amit Shah.
Yes, Dr. Venkat. Actually, as such, these are markers of sensitivity to EGFR targeted therapy. But if you compare mutation to mutation, and depending on what type of TKI you are using, relatively L858R is having relatively less duration of response. But exception is there if you are covering with osimertinib, then that thing is overcome. But if you are targeting with first line TKI, then relative response are less with L858R.
Okay. So, yes, sir, point well taken. Thank you. Dr. Javed Mujamil, sir. So, if you see the exon 21 mutation, is there any other option do you think of?
Yes. I will differ here. That what Flora has shown that there is consistent response in DEL 19 and exon 21 mutation. But if you go for the subgroup analysis in those two different mutations, you will see that around 19 months of the PFS in DEL 19, but in L858R, it is maximum 14 months. So here, if there be no brain metastasis, I will prefer to use erlotinib with ramucirumab, as RELAY trial has suggested, that the progression-free survival in those patients having L858R mutation with ramucirumab with erlotinib will be as good as DEL 19 mutation. So for this L858, if that would be the option, I would use that.
So definitely we have two opinions here. One is osimertinib, one erlo plus bev. Now I would like to ask Dr. Ankit Batra, which side you are on, osimertinib or erlo plus bev?
So practically, I've been using osimertinib only, but I agree with Dr. Javed that what literature says is like that is also erlotinib and also significantly better.
Yeah. So points very well taken. And so we know that now it's not only determining EGFR mutation, but the type of EGFR mutation will also be determine the outcome. The PFS, OS may be difference in these two types of exons that are mutated. But as of now, in the clinical guidelines, as Shalab rightly said, the treatment option do not differ much, but we can choose case-to-case basis. But the most preferred one is osimertinib as per the NCCN guidelines. And in some circumstances, as Dr. Javed has shown us, it is erlo plus bev in some special conditions. Dr. Ankit again. So what are the considerations when you have 3 lung cancer patients on a single day with EGFR exon 19 mutation and 21 mutation? What are the factors you consider and you may choose different treatments in 3 different patients? So what are your primary preferences while choosing the therapy for these 3 patients in your OPD with a metastatic disease?
Yes, sir. In the stage for EGFR mutated lung cancer, as you have already enumerated, like efficacy is the most important, followed by safety. But practically, logistics to be handled is the most important. And we try to, we also know that efficacy with osimertinib has been the best among all. That is, like in the FLORA trial, we have seen that it's somewhere around 18 versus 10 months. So efficacy being the most important, but sometimes because of logistics, we have to choose other options.
Okay. So are there any factors like the sites of disease, tumor burden, and patient? What are the other factors that you consider? Those are the factors I'm asking. Oh, yeah. Obviously, efficacy is one factor we will
Yes.
all look up to.
Talk about the site of disease, CNS disease, at presentation is the most important factor to decide on the PK to use, and the type of mutation also.
Yeah.
So
Sure.
being it exon 19 or L858R, we try to choose osimertinib, but being it a rare mutation, then we choose like other TKIs or chemotherapies as per the other mutations. And if CNS disease is there, in that case, osimertinib being the TKI of choice.
Yeah. Thank you, Dr. Ankit. So now I will move on to the controversial area. Even we can see today in the Twitter there are the fights between PFS and OS groups of the clinical trials. And so for this to give opinion on whether we can choose PFS as a surrogate marker of OS in the clinical trials or not, I would like to take opinion from Dr. Amit and Dr. Javid, who are senior medical oncologists. So which side you are on, sir? PFS or OS? Can we really use PFS in the clinical trials? Because we can see that not all the drugs that increase the PFS will not ultimately turn into OS.
First, the important thing in management of the metastatic disease, whatever be the disease, we are discussing this type, the lung cancer. The first important thing is that quality of life. If the patient is maintaining the good quality of life, you are on the track. That means you are getting the PFS, maybe you will get the OS with the same drug. Second will be the efficacy of the drug, that what we choose in our clinical practice. So as you said, that doesn't matter that sometimes PFS is very good for a drug, but OS benefit is not there. As you see with the dacomitinib, you are getting the PFS in a same L858R, but you are not getting the OS benefit. So nowadays, once you are improving the quality of life, your target is now overall survival. So it changes with time to time. Earlier, we were just focusing on the quality of life, then PFS, now on OS, because you have now data behind you, which can tell you about that you are having a drug which is giving overall survival benefit. So you can choose among 3 different drugs, what drug you can give upfront, and depends upon the other logistic issues also.
Point very well taken, sir. Now, Dr. Amit, your opinion, please.
Dr. Venkat, actually, gold standard is overall survival only, overall survival with maintaining quality of life. That's actually the thing that we aim for. Actually, that's at least one thing that we want that to be there. Maintenance of quality of life and with some implications on overall survival. Other than that, everything is just a surrogate marker or secondary indication that actually we are going to help the patient. So, especially in our metastatic setting, when we are so much worried about quality of life deterioration with first line, second line therapy, and if that is not improving overall survival, I'm not going to choose that option. So, preferred option is the therapy which is going to improve OS with maximum maintenance of quality.
Yeah. So definitely all medical oncologists look at a endpoint of overall survival. There is a, we are all a common platform and there is no ambiguity about that, along with maintaining the quality of life. And now, luckily for EGFR mutated NSCLC, we have one drug that will maintain quality of life as well as benefits in terms of PFS that will convert into the OS finally. That is osimertinib. We all know that And there are several trials that was done between first generation versus first generation versus second generation, and then second generation versus first generation versus third generation. So in all, out of all these, we can see that the longest PFS was seen with the osimertinib. And one of the most important thing is whether it is the exon 19 or L858 or which are biologically different mutations, the benefit is seen with osimertinib irrespective of the mutation. And for specific mutations like exon 21, as Dr. Javed has rightly pointed out, we have other options of ERLO plus BEV also, but the benefit is equally good with osimertinib for both the mutations. And coming to the afatinib or decomatinib, the difference between these mutations, the outcomes are starkly different. We can see here, and so particularly while dealing with mutations that are more aggressive, maybe osimertinib is the drug of choice. So we have seen PFS benefit in both the. And one of the important controversy that decomatinib has accrued over the time is that it has played safely by excluding the brain metastasis, and so now we actually cannot say anything whether it benefits intracranially or not. Also, another controversy about decomatinib is the hierarchical testing, which I will show in the later slides, hierarchical testings, which says that only if B is greater than A, then only B can be compared with C. But what happened in decomatinib trial is B is not greater than A, so it cannot be compared with C. So the hierarchical testing in the Archer trial was that when there is a significant difference or significant improvement in the overall response rate, then only the data set is eligible for the testing of overall survival benefit. But the overall survival was not cannot be given a p-value, or it cannot be tested because the overall response rate is not difference between the two groups. Also, this is the study from the Canadian Kansas, which shows that decomatinib, it clearly concludes that decomatinib does not meet the significance in terms of overall survival because the initial condition is not satisfied, that the difference in the overall response rate between the two arms is not significant. And coming to the most important part, Dr. Ankit Batra. So what is the average percent of brain metastasis you see at the upfront when in a metastatic NSCLC?
So considering our data, sir, like 1/3 of the patient we are seeing upfront with the CNS metastasis.
Okay, how many did you see mostly symptomatic or asymptomatic metastasis?
So like we can say half of them who have been, all the patients who have been metastasis, half of them would be symptomatic and 50% would be asymptomatic.
So Dr. Shalab, previously there used to be a regular question even in Viva of the examination, will you do brain MRI or not? Although in consensus in the guidelines, we are very clear that any lung cancer above stage 1B, we need to do MRI brain. So in your practice, what is the your approach regarding evaluation of the brain in a metastatic NSCLC? And do you think it is really important when we have very important good drugs that can act intracranially as of now? Do you think doing MRI brain and additional investigations is important? And why is that?
I think at baseline, definitely as per guidelines, it is mandated that we have to do MRI brain because be it if we have done systemic imaging or even if we have done PET CT, which is not very sensitive to pick brain metastasis. For my patients right now, I am doing at least a CT contrast of the brain, but MRI would be the better modality. And as for the question whether it is still important with the currently available drugs, I think it is, yes, it is important, because that is one, if we have systemically imaged the patient but missed out a brain metastasis, so we might be missing out on oligoprogressive disease at baseline, irrespective of whichever TKI or chemotherapy we use. So even in the current era, imaging the brain is very important.
You are muted, Dr. Shalab.
Yeah, I had just muted. I said even in the current era, it is very important to do the brain imaging, because we must know at the baseline whether the patient
Yeah.
had metastasis or not. And subsequently, if we
Yeah.
have to,
So as you rightly said, it is very important to do brain imaging. The reason being, in the first line, if you use a single agent, EGFR TKI, it's hardly 20 to 30% of responses intracranially, that to mostly stable diseases. But with osimertinib, we can see it is 66% of intracranial response, which is excellent. But even then, we from this data, we know that nearly 1/3 of patients do progress in the CNS, or they may not have response. So it is very important to know whether we have the baseline metastasis or not, because let's say if the patient is in this 33% of the patients who is not responding to intracranially, then patient might have symptoms, and having that information in hand is very important. Dr. Bhushan, you have mentioned MRI brain in metastatic setting. Why? How you think that is very much relevant as far as the patient outcome is concerned?
Yeah, if MRI brain is first of all, I need to know the status, whether from the start itself, whether the patient is having brain met or not. Hello.
Yes, sir. I can hear
Yeah,
it.
yeah. From the start of treatment itself, brain metastasis is present or not.
So in case in this patient with a single adrenal metastasis and single brain metastasis at the baseline, and patient with EGFR mutation, and patient presented upfront to you, will you do whole brain radiation or go for the surgery? The oligometastatic disease, what will be your approach?
No, definitely surgery I won't do right now. I will refer to our medical oncologist colleague, and whole bone radiation won't be an option, because when we have better drugs available.
Yeah, thank you. So with a better and better intracranial active drugs, maybe at least in a few patients who are asymptomatic, who do not have metastasis in a critical areas like cerebellum or CP angle, we can actually avoid a whole radiation and then move on to the TKIs. So Dr. Ankit, let's say this patient has PD-L1 positivity of 70%. So will that in any manner favor the option towards immunotherapy rather than waiting for the molecular profile? Because PD-L1 is done by IHC, you have a report in hand, patient has come with 70% of PD-L1. So, and patient is affordable for all the therapy. Will you start immunotherapy, or will you still want to wait for the molecular report?
No, sir. No, sir, not at all. I would definitely wait for driving mutation like EGFR, because we all know that patients who have a EGFR driver mutation do not do very well with the anti-PD-L1 checkpoint inhibitors. So that will be a big no for. I will definitely wait for other driver mutation.
Yeah. So it was seen that any tumors with driver mutations, including EGFR, ALK, RAS, MET, or any other driver mutation, they do not respond well to the immunotherapy, except one of the subgroup, that is, I think, red group, which do not usually respond with the immunotherapy drugs. The interactions, we are understanding the biology better. The interactions are not completely understood, but as we have two senior oncologists here, let us try to understand, is there any known mechanisms why the immunotherapy will not, because there are two independent mechanisms. The one is immune system that is trying to control the tumor, other is the internal driving mutations. So Dr. Amit and Dr. Javed Mujamil, is there any factor that we know yet that why immunotherapy is not effective in driver mutated tumors?
Dr. Venkat, with current level of evidence, actually, there is also not, this statement is also not uniform that all EGFR IO are absolute contraindication. So with current evidence and current level of recommendation, they suggest that only exon 19, L858R, and ELK. These three are like absolute exceptions that you should not try immuno-oncological drugs. And there are studies, there is literature that says that there is a change in microenvironment milieu in this group of the patient. As such, they are having low microenvironmental immunity, so that inhibition of PD-L1 is not going to help much. Rather, that's a actually marker of relatively poor prognosis. And that too also, that is also important, that is irrespective of magnitude of PD-L1 positivity. So even if it's 70-80% PD-L1, if patient is having exon 19 L858R or L, then IO are no. Having said that, even after like first line of osimertinib, if we are planning immuno-oncological drugs later on, or vice versa, still in that setting also, there is evidence that there is more chance of ILD, interstitial lung disease. And there have been trials that they try to combine osimertinib with immuno-oncological drugs. So those trials were stopped in between because there was like about 38% of pulmonary toxicity. So efficacy is less, toxicity is more. So that's why, but exception is rarer or newer EGFR mutations. In that data is not that clearly defined.
Yes. Point very well taken, sir. The reason is while we're focusing on the trees, we should not lose the view of the forest. While looking at the tumor shrinkage, cancer cells, we should not lose the view of the organ system of the patient and patient as a whole. And so we should keep the side effect profile in our mind while treating, including the quality of life, is all spiritual, mental, and physical being, and side effects in particular. So points very well taken. Dr. Javed Mujamil, any inputs from your side regarding this point?
Definitely, whatever Dr. Amit has said, I will concur on that, and I will comment that in future, that if a patient has received TKIs, first generation, second generation, you can give even oncology drugs once they progress with chemotherapy in second line or in third line. There you can give, it's not absolutely contraindicated. Then you will not get that benefit what we used to get with in other patients where there is no driver mutation. But there is definitely benefit of adding immuno-oncology drugs, but in subsequent lines, not in front line. Absolutely no for that.
Okay. And in particular, I will ask another question. Are you avoiding brain radiation in patients who are having cerebral metastasis, non-critical areas, and going for osimertinib alone?
Yes, if they are asymptomatic, definitely. But if I feel that patient may land up in a problem and the size of the disease is very much, if I have SRS available, we go for the SRS or neurosurgical intervention.
Okay, thank you. So these are the very important points we learned from the panel discussion. And coming to the safety summary of the first-line metastatic EGFR mutations. So the most important data that gives us an idea of the safety of drug is the dose reductions that are required. So we can see here in the from the Lung 7 trial, nearly half of the patients, they required the dose reductions because of, we know it causes severe diarrhea and fatigue. In Archer trial, we can see nearly 2/3 of patients, they required the dose reduction. But in FLAURA trial, osimertinib is a molecule that is very much convenient for the patient as well as the physician, requiring very small amount of intervention while we have started a drug in the patient. Only 4% of patients require the dose reduction. See the contrast. This is the safety profile that we want to look at. So coming to the quality of life, this is well discussed in our in our panel discussion today, and we can see here the when we see the quality of life trials, the global quality of life, it is very much well maintained with osimertinib compared to any other previous generation TKIs. Usually in majority of the molecules, when we see the more and more aggressive with the molecule, the quality of life usually deters because of its aggressiveness and the side effects. But here in osimertinib is one drug which does not actually even cause a lesser rash because it does not act upon the wild type EGFR receptor. So this is previously this question used to be very significant whether we start with first line TKI and osimertinib. Now this question I think became irrelevant with the availability of more and more data about the efficacy of the osimertinib, including the intracranial response. So one of the most important reason we should use the best drug. The best drug in the first line is that we know that as a tumor progresses and the patient performance status decreases, the number of patients who may receive second and third line will be less and less. So rather than waiting for a flight at the second step, getting AC train is better in the first step. So this is how geotag study has shown that maybe the afatinib may be better, but this is this has its own setbacks. And now coming to the conclusion, osimertinib is a molecule that has resulted in significant improvement in the PFS or the standard of care, that is the first line EGFR TKIs. 18.9 months is the PFS we have achieved compared to the less than 1 year PFS with the first generation. Only osimertinib is the one which has a clinically meaningful OS, including the CNS PFS, and it is the monotherapy that has improved, achieved a significant OFS. And after 3 years, nearly 28% of the patients with osimertinib and only 9% of the patients in the first generation TKI remained on the first line treatment. So with regard to toxicity profile or the benefits it is providing, osimertinib is the drug of choice. This is the conclusion of the today's panel discussion. With this, I end my panel discussion and thank all my panelists, Dr. Shalabh, Dr. Ankit, Dr. Amit Sherawat, Dr. Bhushan Tombare, and Dr. Javed Mujamil sir. Thank you so much for your time.
So thank you so very much, Dr. Venkat sir. As always, a brilliant presentations and moderation of this panel. And thanks to all the esteemed panelists for a part of it. So we move forward, and the next is a talk, and this is the academic partner for this is Novartis. So it's a pleasure to invite on the floor Dr. Devrat Arya, Director, Department of Medical Oncology from Max Healthcare Hospital, Delhi. And Dr. Devrat sir is going to talk on ceritinib, a frontier in the first-line treatment of ALK-positive NSCLC. Dr. Devrat Arya, the floor is yours, sir.
Yep, thank you very much. First of all, thank you, Dr. Venkat. Excellent talk, and all the panelists, excellent moderation. I think you were able to cover all the salient points that are very relevant to the usage of variety of different EGFR inhibitors. And I think we move on very quickly to the ALK inhibitor space. And like the anti-EGFR or EGFR mutated space, even in ALK inhibitors, we are actually looking at a variety of drugs that can be used. And the question that we often ask is, what is the best way to move forward? Which one is the preferred drug? So I hope my slides are visible.
Yes, sir. Yeah, it's visible.
So we heard Vikas earlier how the different oncogenic drivers actually defining the way we treat our patients with advanced non-small cell lung cancer. I think the number of mutations that are known to be a driver mutation is actually increasing with as time is passing by. We have newer targeted drugs available for each of these agents, and while EGFR mutation has formed the bulk of these mutations, increasingly we are recognizing that a significant number of mutations are ALK rearrangements. We have significant number of MET exon 14 mutations, RET fusions, MET amplifications, MET exon NTERT mutations, and so on and so forth. And we also understand that while it's significantly the adenocarcinoma patients who are, the most likely ones to be harboring this mutation, we also know that considering the fact that in most advanced non-small cell lung cancer, it's a small biopsy which establishes diagnosis. There's also a significant number of squamous cell carcinomas, especially patients who are non-smokers who may also harbor these mutations. In fact, we also know that MET exon 14 skipping mutation may in fact be seen in smokers. So increasingly we are recognizing that all non-small cell lung cancer patients should be increasingly subjected to testing for these individual mutations. Now, we also heard how one could do individual tests. So one could do a FISH, or for example, a PCR for a EGFR mutation. One could look at ALK rearrangement using a IHC or a FISH or NGS. Similarly, we have individual tests.
Excuse me, sir.
Yeah.
Sir, click on play button to go for slideshow mode, and slides are not moving. We can see only first slide.
Oh, okay. So let me exit, escape, and then.
Yeah, now, please. Yeah, now click on share screen button and click on first option screen. Yes, sir. Now click on play button, sir.
Is it moving now?
No, it is not coming in full screen, sir. Sir, please follow the steps which am I saying, sir. Please stop share, sir, firstly.
Okay.
Yeah, click on share screen button and click on first option, sir. Screen or desktop एक first option होगा whiteboard से पहले, sir.
Screen
उस पर क्लिक
desktop.
करके शेयर कर दीजिए सर.
Okay.
Yeah, now perfectly coming, sir.
And it's full screen now.
Yeah, now coming, sir. You can go ahead, sir.
Now let me see if I am able to move it or not.
Sir, click anywhere on the slide, it will move, sir. Yeah.
Okay. So, so the one option is actually to look at these individual rearrangements and mutations. Now we know when we talk about non-small cell lung cancer, tissue is always an issue. We are usually short of tissue, and in my own personal practice, especially in those settings where not all of these tests may be available in-house, you end up getting results for the less common mutation, and some of the more common mutations may be left untested simply because the tissue ran out. And I think increasingly what we are realizing is that there's a need to shift to a more universal testing platform. I think one platform that really helps is next generation sequencing. When you look at different guidelines, including the NCCN and the ESMO guidelines for non-squamous, and I believe increasingly for all non-small cell lung cancer, it's very imperative that we test for at least EGFR, KRAS, BRAF, ALK, MET, exon 14 skipping, RET, ROS1, NTERK, and PDL1. But I think increasingly what we are looking is that if you are going to look at these tests, look at these mutations, rearrangements, NGS offers the option of doing a one-time testing for all these. So this is the NCCN recommendation, recommends that all these individual mutations or rearrangements be tested as a part of broad molecular profiling to minimize tissue use and potential wastage. And so does ESMO guidelines, which recommend that multiplex platforms, that is NGS, is preferred for molecular testing. And increasingly, because you have more and more biomarkers being identified, and while we know that NGS would potentially would mean that the turnaround time is longer, it certainly is a one-stop option for the testing. I think we also understand that there are certain challenges with NGS. So we know the cost of testing is going to go up, and it's not just the cost of testing that the patient pays, but also the laboratory that installs the infrastructure. We have technical challenges, how well the labs are looking at DNA, RNA, particularly fusions, the accessibility of NGS, the potential of false positive, and as I said, the turnaround time. But I think overall, against the backdrop of these negatives, we have the fact that they are very reliable in detecting known standard of care mutations with a fairly good sensitivity and specificity. It's accurate identification and up to 3 times more clinically actionable alterations compared to the individual testing, may provide data on all mutations. And as the field is advancing, what may be not relevant today may become relevant down the line. And I think increasingly we are realizing that laboratories are making tests available. For example, Novartis and some other companies are sponsoring the test called GeneEvolve in partnership with Lal Path Labs. And in a more targeted lung cancer driven mutational landscape, they're actually through this platform looking at single nucleotide variant genes, that is DNA based sequencing for ALK, BRAF, EGFR, ERB2, KRAS, MET, NRAS, PIK3, ROS1, TP53, and NTERK. And importantly, they are also looking at fusion genes, that is RNA-based sequencing like ALK, RET, ROS1, and MET exon 14 skipping. So one example how NGS could potentially, over a period of 10 to 14 days, test all these mutations and then come up with different treatment options, or at least give the treating medical oncologists different options when it comes to treatment of these patients who otherwise have very challenging diseases. Now coming to the core topic, that is ceritinib. Now we know we have different ALK inhibitors in the first line space, and we've looked at drugs like alectinib, lorlatinib, brigatinib. But we also know that crizotinib and then ceritinib were one of the first drugs that came into space, and it makes sense to revisit some of the data. And so the first trial that I'm going to talk about is the first line ceritinib versus chemotherapy in patients with ALK rearranged non-small cell lung cancer. This was the ASCENT-4 study. Remember, This was a study which was initiated when crizotinib was not yet the standard of care. So the key inclusion criteria were ALK positive, locally advanced or metastatic non-small cell lung cancers, were treatment naive, who were then randomized to pemetrexate-based chemotherapy, which was the then standard of care, or ceritinib at the dosing that was evaluated at that time, that was 750 milligrams. Patients were stratified as per their performance status, presence or absence of brain mets, and prior neoadjuvant adjuvant therapy. And patient could receive the drug till progressive disease. And in fact, the clinician had the option of continuing beyond progression if the clinician felt that there was benefit beyond progression. And those patients who were randomized to receive chemotherapy had the option of continuing pemetrexate as a maintenance. And there was an optional crossover to extension treatment to ceritinib for these patients. So what were the results for ASCENT-4? Ceritinib doubled the median progression-free survival from 8.1 months for the chemotherapy arm to 16.6 months for the ceritinib, which actually eventually meant that there was a 45% reduction in the risk of progression or death. There were secondary endpoints which actually confirmed the efficacy. So the overall response rate with ceritinib was 72.5%. Patients who responded had a duration of response of nearly 24 months. And importantly, the 2-year overall survival rate was 70% for this population. Now, we also are very keen to understand what is the implication of the drug on Asian patient. And now I do understand that most of the Asian patients in these studies are usually Southeast Asian patients, but still, when you look at the Asian population and the Asian patient subgroup analysis, even in the Asian patient population, there was significant improvement in progression-free survival from 10 months to 26.3 months, and which meant that there was a 34% reduction in risk of progression or death. So fairly impressive and equally impressive outcomes even in the Asian population. ASCENT-8 then looked at the Asian population specifically. So this was a study which included stage 3B to 4 ALK rearranged non-small cell lung cancer who were treatment naive, where ALK had been tested through the Ventana IHC or the FISH platform. And a patient with brain mets who had a neurological stable brain mets were included in this study. And they were randomized to 3 different doses of ceritinib. So they were looked at ceritinib at a low dose, which is 450 milligram per day. And that is the conventional dose that we use now with a low fat meal, versus ceritinib at 600 mg per day. And then at that time, the standard of care ceritinib 750 mg per day under a fasted state. And again, ceritinib could be continued until unacceptable toxicity or disease progression or withdrawal of consent, or at the discretion of the investigator. Obviously, they looked at primary endpoint, the pharmacokinetics. So the steady state PK of ceritinib at the different doses, but the key secondary endpoints for overall response rate and duration of responses. And what were the results? So this is the Kaplan-Meier plot showing the duration of response. So A is the duration of response, and the maroon line is the ceritinib lowest dose, and we can clearly see that the probability of being event-free was highest in the lower ceritinib dose at 450 milligram per day, and fairly impressive. And although it's a cross-trial comparison, fairly impressive when you look at the historical data of chemotherapy. Again, when you look at progression-free survival by the blinded review, the best progression-free survival rate was with the lowest dose at 450 milligram subgroup, and clearly, when you look at individual figures, overall response rates highest at 83% for the 450 mg dose compared to 80 or 77% for the higher doses. Disease control rates nearly 97% for the lower dose compared to approximately 90% for the 670 750 mg dose, and median duration of response not evaluable, not achieved. I mean, data is still immature, but again, possibly highest with the 450 mg dose, and DOR rates at 24 months. So 70% with the 450 mg dose compared to 45 and 20% for the 600 and 750 dose. And again, so possibly the most impressive results coming from the 450 mg dose. So they concluded that there were numerically higher overall response rate, median duration of response, 24-month DOR rates, median PFS, and 24-month PFS with the 450 mg dose, and the 36-month OS rate was 93%. So this is very impressive. 93% at 3 years for the 450 mg dose compared to 70% in the 750 mg dose. Now, I think one of the other factors when we talk about ALK rearranged non-small cell lung cancer is the incidence of brain metastasis. So we know that nearly 30% of patients with ALK rearranged tumors would have brain mets at baseline, and that figure sits much higher than some of the other driver mutation driven non-small cell lung cancers. And we also know that brain mets is one of the significant causes of progression, particularly with the first generation ALK inhibitor crizotinib. So when you look at the crizotinib data, CNS was the primary site of relapse in almost half, that is 46% of all patients treated with crizotinib. And when this data was looked into, there was a greater acknowledgement of the need that we needed next generation ALK inhibitor, which had increased blood-brain barrier penetration, not only in the subsequent line setting, but also in the first line setting. And when you look at ceritinib, and remember ASCENT-4 included those patients who had stable brain mets at baseline. When you look at ceritinib, the median PFS for those patients who received chemotherapy and had brain mets at baseline was 6.7 months, and this was improved to 10.7 months for those patients who received ceritinib. And when you look at 2-year median PFS, these are the figures, and this is again an improvement in PFS rates even in those patients who had brain mets. And when you look at intracranial responses, again ASCENT-4 compared ceritinib versus chemotherapy. So with chemotherapy, the intracranial response rates were only 27%, but when we look at the arm which had ceritinib, they were as high as 73%. So there were higher responses and more durable clinical benefit in the brain with ceritinib. So clearly showing that ceritinib is not only active in the brain, it not only crosses the blood-brain barrier, it actually leads to durable responses and significant overall responses in the brain as well. Again, back to the ASCENT-4 Asian patient subgroup analysis. When you look at the whole for the entire population, we do know that ceritinib achieved a higher overall intracranial response rate, intracranial disease control rate in patients with both measurable and non-measurable neurological stable brain mets, even in the Asian subgroup. So it is active in brain, it's also active in brain within the Asian subgroup of the study. Now, the other question that was asked at that time was, how does ceritinib stack up against crizotinib? Because crizotinib, when the ASCENT started, was not the standard of care. So what was done was an adjusted indirect comparison with external control. So this is a cross-trial comparison, but nevertheless, what the data showed that ASCENT-4 included more current smokers, near double the rate of current smokers, and fewer patients under the age of 65. So possibly a higher risk population is ASCENT-4 compared to Profile 1014, which looked at crizotinib versus chemo. And compared to crizotinib, ceritinib was associated with significantly longer PFS. Median PFS was 25.2 months for ceritinib compared to 10.8 months, so nearly 11 months with crizotinib. And in the adjusted indirect comparison with external controls, second generation ALK inhibitor ceritinib was associated with overall improved outcomes in the first line setting compared to crizotinib. So this is the data: median PFS of 10.9 months for crizotinib versus 7 months for chemotherapy. At 1.5 years, 31% patients progression-free for crizotinib versus 5% for ceritinib. When we look at the ASCENT-4 data, a longer median PFS 16.6 months for ceritinib versus 8.1 months for chemotherapy. And again, at 1.5 years, 50% of patients progression-free in ceritinib compared to 23% in the chemotherapy arm. Similarly, when you look at overall survival, we know that there's no improvement in overall survival, although the hazard ratio was 0.76 for crizotinib. But when you look at ceritinib, there's clearly a longer median OS for ceritinib compared to chemotherapy. And when you look at safety profile as well, Serotonin, in fact, significantly improved quality of life and significantly prolonged time to deterioration for lung cancer specific symptoms compared to chemotherapy in the ASCENT 4 arm. We know that when you look at all grades, there's a significant number of patients who would have diarrhea, nausea, vomiting, derangements of liver enzymes, decreased appetite for serotonin. But when you look at the grade 3-4 side effects, the highest incidence is actually for the paper side effects, that is derangement of AST, ALT, and GGT. When you look at grade 3 diarrhea and or grade 3 or 4 diarrhea and nausea, the incidence rates are much smaller for serotonin. Now, we have this cross trial, so sort of competition between a variety of other drugs. So serotonin obviously was a second generation ALK inhibitor, so is alectinib and so is brigatinib. We also have the results from the CROWN study with lorlatinib, which is a third generation ALK inhibitor. And in the absence of, while these drugs have gradually become available, in the absence of cross trial comparisons, actually very difficult to draw a conclusion to say that one is better than the other. I think that's acknowledged by the NCCN guidelines, which even the latest version says that for the ALK rearranged non-small cell lung cancer, the first line therapy category 1 recommendations continue to include alectinib, brigatinib, lorlatinib, but also very importantly serotonin for this population. I think in a cost sensitive country like India, cost effective sequencing is also very relevant, particularly when you don't have data to say that one drug is better than the other. And when you look at data from serotonin, median PFS of 26.3 months in the first line setting, and then for these patients, alectinib and lorlatinib can also be active subsequently. And potentially, again, this is cross-trial comparison. So this is a hypothesis generating a slide more than anything else. But potentially the longest sequence with the TKIs if one starts serotonin in the first line setting. So as a medical oncologist, what are the different points I consider while I initiate a patient on an ALK inhibitor in the first line setting? Obviously, superior efficacy is very important because a significant number of these patients may not, as many as 1/4 of these patients may not survive to receive second line. So you need to use the most efficacious drug. We know that brain mets can be present at baseline, and therefore use of brain penetrable TKI is very important. We know that brain mets can also be a reason for repeated radiotherapy, and therefore brain penetration ensures that the need for repeat radiotherapy may be reduced in the future. With symptomatic disease, you need drugs which have good response and rapid response. And when the patient eventually does progress, it's very important that as a medical oncologist, I want the patient to be chemo free, and therefore second line TKI is what I look at. And therefore, in my mind, the sequencing would include a first line TKI followed by a second and third line TKI rather than TKI followed by chemotherapy. So I'll quickly conclude. ASCENT-4 trial in ALK inhibitor naive patients with ALK rearranged non-small cell lung cancer showed that serotonin significantly improved PFS and numerically improved OS. The data was not mature at the time of reporting for OS. A PFS benefit was seen regardless of the presence of brain metastasis. Gastrointestinal adverse events were common but were manageable. And when you look at grade 3 and 4 adverse events rates, they were very small. And the efficacy and safety of serotonin was well established in the Asian patient population in this space. So thank you very much for your patient hearing. Thank you once again. So I think I'll very quickly move on to the next session. Again, sponsored by Novartis. So the next session is a talk on capmatinib, the unmet need in MET exon 14 skipping mutated non-small cell lung cancer. And to give this talk, we have Dr. Akhil Kapoor, a very good speaker. He's an assistant professor, medical oncology at Tata Memorial Hospital, Varanasi. So over to you, Dr. Akhil. Dr. Akhil.
Yeah.
Yep.
So thank you for inviting me. So I'll be sharing the presentation of capmatinib. Definitely, this is one of the unmet need, and we now have some good data for the utilization of this drug, and we have now good experience as well from the compassionate access ground. Now having a phase 4 trial, all these things actually add to our experience and the benefit of the patients. So let's start with the disclaimers. Slides have been provided by Novartis. MET mutation, yes, MET exon 14 skipping mutations contribute around 3% of all mutations. So it is very important to test for this. Now, why we were not able to find this mutation for so long time? Because the quality and the sensitivity of NGS which was being done was usually DNA-based NGS. Now we understood RNA-based NGS is very much better, has much better sensitivity to identify this mutation. That is why our awareness has also increased, and we yes, it is it can be identified. Now, in which of the patient you would never miss a testing for MET mutation? It is sarcomatoid tumor, sarcomatoid carcinoma. We know the mutation rates will.
Akhil sir, your presentation is not moving.
So I'm on the first slide only till now. I was on the MET mutation sequence percentage. So sarcomatoid carcinoma is having around 12% mutation rates, and that is why it is very, very important to in sarcomatoid cancers. So what is already known about this mutation as a prognostic factor? It is very clear that this mutation has known to have a poorer outcomes if MET inhibitor is not used. MET mutation, if you don't you target it with a MET targeted treatment, you can clearly see the outcomes are very, very poor, and the graphs clearly show the wild type versus MET mutated. The curves are widely separated even in this small subgroup of the patients. So it is very important to understand. And this is also known to have very extremely poor response to immunotherapy. So it is somewhat like EGFR only, where we know the responses to immunotherapy is not good. We always tend to start immunotherapy when there is no EGFR or ALK, but we know that if MET exon 14 skipping mutations identified in the NGS, definitely our patients are not going to do well with immunotherapy. Response rates are only 17%, and you can see partial response rates are very, very low. In fact, maximum patients are having progressive disease. So that is a very worrisome phenomena. That is why it is important to test for this drug, test this mutation. So if we see, we have identified a poor prognostic subgroup. Can we do something to improve the survival? Yes, there is a targeted treatment available, and if we know from our experience, targeted with the targeted treatment, that is the best which can be done with the patient, and it is very important to identify. So if you can clearly see the overall survival for patients who never received a MET TKI, it was only 8 months, whereas when the patient could receive a MET TKI, the overall survival jumped to 24 months, tripling of the overall survival. This is very, very important, and this is a huge difference in the outcome of the patients. So if we see, we know there are some drugs like crizotinib, which is already available very well and very common in use. Crizotinib is also some MET inhibitory activity. So why not to use crizotinib or some other drugs like cabozantinib? Crizotinib, if you see IC50, 22.5 nanomole IC50 will be required for crizotinib. Similarly, it also requires 7.8 times IC50. For tepotinib, it is 3. For savolitinib, 2.1. For capmatinib, it is 0.6. So it is one of the most specific and most potent MET inhibitor. This is clear from this IC50 data, and this really makes sense in the real practice. You can clearly see capmatinib, savolitinib, tepotinib, which are the 3 specific selective MET inhibitors. Out of these three also, capmatinib is having the strongest and most potent activity. This is the initial trial geometry mono-1 design. I will concentrate only on specific subgroups. The cohort 4, where there were patients are pre-treated with metoxon 14 regardless of MET GCN, and cohort 5, there were two groups. MET GCN was more than 10 with no exon 14, and in cohort 5B, MET exon 14 was there regardless of MET GCN. So these patients were treated with 400 milligram BD capmatinib. So objectives were to demonstrate anti-tumor activity of capmatinib, and endpoint was overall response rate. And we'll see the data for the same. Let's see for MET exon 14 skipping mutations, cohort 4 and cohort 5B, which are the two important cohorts which we want to analyze in our practice. 70 patients in cohort 4 and close to 30 patients in cohort 5B. Age, you can clearly see it's median age was 70 plus. So that is very clear. These patients are older age patients with around 80% patients are having age more than 65 years in both the groups. In treatment naive cohort, you can see 90% patients are more than 65 years. And if we see the smoking history and everything, around 40% patients were smokers, ex-smokers. So that is somewhat similar, but not much different from EGFR data, and that needs to be continued. Around 15% patients were having baseline brain metastasis as well. So this is an important point, and we'll come to that as well. And also for the MET amplification, we know for MET amplification, if the ratio of amplification is between below 4, it is classified as not so important. Between 4 to 6, yes, it can be considered. Beyond 6 to it is usually considered as very significant. In practice, for the first line treatment, you will treat with the MET directed treatment like capmatinib if there is exon 14 skipping mutation. From second line treatment onwards, you can utilize the drug if there is more than 4 MET GCN with amplification. This is the data of the prior therapies. You can see most of the patients have received prior platinum-based chemotherapy. Around 30% had received immunotherapy as well. And if we see the overall response rates, best overall response rates, investigator initiated as well, and also by the blinded review, 35 to 36% patients. So overall response rates became 40%, and disease control rate was 78%. So out of 4 patients, every 3 patients are having disease control. So this is very important to be noted, and this is what needs to be taken to home. In cohort 5B also, you can see the patients who are treatment naive, overall response rates are to the tune of 70%, and disease control rate is close to 96%. So huge responses. That means in nearly every patient, you know, their disease will be controlled for some amount of the time. So that means this is a very targeted treatment, a specific treatment, and this can be noted. These waterfall plots will make you just think about the previous curve for immunotherapy, where we're seeing most of the patients are progressing. And now when you see these curves, waterfall plots, you see nearly all patients are having response. In cohort 5B, no patient had any increase in the tumor size. In cohort 4, only 1 patient had increase in tumor size. Rest all either it was stable or it was significant decrease. Decrease was there in all the patients. However, there is some cutoff for the RECIST criteria. That is why you can see disease control rate is to the tune of 74%, while control overall control response linkage is around 55%. If we see the duration of responses, yes, that is what I wanted to highlight again. The responses are sustained. This is not a short-term response. These are sustained till at least a year. In cohort 5B, it was crossing 1 year. And in cohort 4, it was just below 1 year, that is around 10 to 11 months. So this is another important point. Median PFS, if overall is considered, it was 5.42 months in cohort 4 and 12.5 months in cohort 5. And this is the Swimmer's plot for the responders. You can see the ongoing responses very clearly. There are rapid and durable responses in both the cohorts, with the onset occurring at even at the first tumor evaluation. So when you are evaluating the patient at the 8 weeks, even at that point, you can see most of the patients have significant responses. So responses are quick, responses are sustained, and these are long lasting responses for at least a year, especially in patients who are treatment naive. If we see that activity in the brain, as I had highlighted, around 15% patients had baseline brain mets. You need to understand 54% patients had good intracranial response. You can clearly see the tumor. This has come down significantly, and it is not recognizable in the next series of the scans. So it is very, very clear, and you can clearly show. And if we see these are the shrinkage by MET alterations, it is very clear. Exon 14 is regardless of other amplification, MET exon 14 will have very good response regardless of any amplification. This is updated results, recently updated in 2020 NEJM, and this clearly shows the expansion cohort results were also given. The results are maintained, around 70% overall response rates, with disease control rates going to 96% in cohort 5B, and this is really, really important response. A huge number of patients are having significant response. Even in the second line treatment, the response rates are 51%. And third line, further beyond, it is to the tune of 40%. Targeted treatment, if you reserve it for the later lines, what happens? The patients have deteriorated in performance status. They have reduced reserves. So the drug might not have optimal responses. That is why try to identify the mutations at the earliest and utilize the targeted treatment with capmatinib at the earliest, so that the patients can have long-term responses. And as I have told, the median duration responses were more than a year in the first line and close to around 9 to 10 months in the second and third line. So there is clearly a clinically meaningful median overall survival advantage, and patients are surviving to 22 months. And if we are using in the second or third line, what are the important toxicities? There are some amount of peripheral edema. It is somewhat similar to crizotinib, to which we are very much accustomed. And this drug is also similar activity. Some gastric disturbances with gastritis, yes, it can occur, like we have seen in crizotinib also. Similarly, some patients have increase in blood creatinine, but it is usually doesn't reach to the significance of requiring dose reduction or significant increase requiring dialysis. This usually doesn't occur, and some amount of increase in creatinine and LFT is feasible, can be seen. So the preliminary results efficacy of the expansion cohort 7 suggest around 65% response rates, and these are comparable both in treatment naive patients with MET exon 14 and the pre-treated patients also. The response rates are huge. Every second patient will have good response in terms of those tumor size reduction. 51.6% in cohort 4, second or third line, it will be around 40%. If we see the median overall survival, it is around 21 months and 13.6 months in patients who are treatment naive and pre-treated respectively, and side effect profile is manageable. And updated results confirm that MET exon 14 is a targetable oncogenic driver, and it strengthens the evidence for capmatinib. These are the basic statement. At the same time, I would like to share my experience of capmatinib. We had started patient of capmatinib with compassionate access program when it was not available commercially. The patient had received CTRT in the stage 3, and after that, in the first response evaluation, the patient was found to have progression, and NGS result showed MET exon 14 skipping mutation. Patient had somewhat poor PFT, and it was known to have some component of ILD also. That is why we were very initially, since we didn't have any experience, we were very cautious to start. But we found the patient had a very great response on capmatinib. The patient was on capmatinib for more than 14 months. That was good, and the patient didn't have any deterioration in the pneumonitis. In fact, it gradually improved with time as the radiation effect died off. So these have been a good experience. Now we have a phase 4 trial at TMH Varanasi as well, We look forward to give the benefit to more and more number of patients. With this, I would like to stop here. Thank you and greetings from Team Insurance.
Yep. So thank you very much, Dr. Khil, for this excellent talk, as always. I think it's a new drug, and it's very important that we as colleagues share our individual experiences. So I've had a couple of patients. In fact, one of the patients that stands out is a 80 or nearly 80-year-old gentleman who had a non-small cell likely squamous and a heavy history of smoking, and we were very keen to avoid chemotherapy. So while we did start him on a taxane-based weekly chemotherapy, we did the NGS, came out as Metaxon 14 skipping, started him on Capatinib. He seems to be responding well. We'll probably have a re-evaluation very soon. But again, I think brings out the fact that probably in this current era and age, most of the patients with non-small cell lung cancer should be subjected to an NGS. And if you have a targeted mutation, it does work. And there probably is a learning curve with all new drugs, but once we understand that curve, we understand how to handle these side effects. I think it can really make a difference in terms of how the outcomes are for these patients. So thank you again. Thanks you once again, Dr. Khil. And we'll quickly move on to the subsequent session. So very important set of talks coming up. So what we are going to talk about is, and these are Roche sponsored sessions. So importantly, we know that for advanced non-small cell lung cancer without a driver mutation, there are a number of immunotherapy drugs that are available. We don't have a head-to-head comparison between different drugs. And therefore, it becomes very important for us to understand the nuances of the trials of these individual drugs, individual immunotherapy drugs, and how they've affected outcomes. So the next talk is treatment strategies with atezolizumab in the first line metastatic non-small cell lung cancer. And to give this talk, I invite my dear friend and colleague, Dr. Shefali Sardana, who's a senior consultant medical oncologist at Max Super Specialty Hospital, Saket, Delhi. So over to you, Dr. Shefali.
Thank you, Dr. Arya, for introduction. And can I share my screen?
Yeah, sure, ma'am.
Right. So is the screen visible?
Yes, ma'am. The screen is visible.
Right. So good evening, all. And like Dr. Arya highlighted, so we have options of immunotherapies, vast options of immunotherapy and immunochemo in actually advanced non-small cell lung cancer, changing its paradigm totally. And today I'll be talking on role of atezolizumab in first-line non-small cell lung cancer. Where does it stand? And so to talk about atezolizumab, I mean, my next couple of slides would be highlighting on a slide on, say, disease background, setting the context, and then how the landscape of lung cancer treatment evolved, and a role of atezolizumab. And having said that, 3 studies which are important to highlight atezolizumab are IMpower 110, 150, and 130. So I'll be talking about atezolizumab in the next couple of slides. So as we all know that, I mean, before the era of, say, targeted or immune checkpoint inhibitors, the overall survival in advanced non-small cell lung cancer was dismal. Actually, only the arm of chemotherapy was there before the driver mutations also got picked up. And I mean, it was a lost hope. So then came the era of driver mutations, where we had a certain quantum of hope for subset of patients who actually had this driver mutation positive, but a large a group of patients who did not have this driver mutation positive, we were still looking forward to some hope in terms of some targeted or other options available. We know that non-small cell lung cancer accounts for about 85% of all lung cancer, 15% being the small cell subset. And out of these non-small cell lung cancer, we know that 15% are never smokers. Median age is 70 years. I mean, now the age is preceding a little bit. And the metastases occur later in the disease process, with 55% of the patient have distant disease at the diagnosis itself. And as we know that apart from the driver mutation, the targeted agents and newer immune checkpoint inhibitors have actually changed the treatment paradigm of non-small cell lung cancer. If we see the landscape of lung cancer treatment, how it evolved till 1980s, we had only the chemotherapy arm, and I mean, the hopes were not there. And then we look about in non-driver mutation positive patient, we looked about bevacizumab as the targeted agent. And then, I mean, the landscape of various checkpoint inhibitor came into picture. So if we see the patients of advanced non-small cell lung cancer with no actionable biomarker, or for that matter, no driver mutation actually. So overall survival was stratified in this graph as per the therapy received. And we see that clearly when the targeted therapy, or for that matter, any additional agent is added or replaced over and above chemotherapy, it adds on to survival. Because we see if the molecular profiling of non-small cell lung cancer, we have all wide spectrum ranging from unknown mutation to KRAS, EGFR, HER2, BRAF, ALK, PIK3, and now the PD-L1 also. So if we try to see the role of atezolizumab in first-line treatment of advanced non-small cell lung cancer, we have these 3 studies to talk about. So IMpower 110 basically tried to look into, is atezolizumab monotherapy a better agent than chemotherapy in PD-L1 selected chemotherapy naive subgroup. And IMpower 130 actually tried to look into if we can spare cisplatin or the steroid sparing chemotherapy regimen in this armamentarium. And IMpower 150, I mean, as we all know, the main highlight of this trial was actually the involvement of driver mutation patients also. So it actually looked, tried to see whether the addition of atezo to over and above chemo plus targeted, that is carbopecli and bev, will add on to the advantage or not. So if when we see 110, basically it included all patients irrespective of the histology, and it tried to compare atezo monotherapy with the platinum doublet, and the choice of chemotherapy would depend upon the histological subtype. So it randomized the all advanced stage non-small cell lung cancer patients who were PD-L1 selected and they were driver mutation negative. They randomized into atezo versus chemotherapy arm. And what they tried to see is to divide the patient subgroup into 3 groups. So one was intention to treat analysis of all patients irrespective of the PD-L1 expression, then the PD-L1 high expressor and the mid expressor. So all of the arms, both of the arms were at par matched in terms of the baseline characteristics. And if we see the overall survival in PD-L1 high expressors, so the median 6-month overall survival was 76.3% as compared to 70.1 in the chemo arm, and 12-month overall survival was 64.9 months versus 50.6 months in the chemo arm. So hazard ratio was impressive, it was 0.59. So it again highlighted, like we know that in PD-L1 high expressor, I mean, immuno single agent is a good choice as compared to the chemotherapy arm. So again, I mean, though the PD-L1 is not considered as an absolute biomarker, but although it gives a level of confidence if we see PD-L1 high expression in somebody, so that it gives a liberty of sparing that subset of patient population from chemotherapy. So if we see this forest plot, it clearly, I mean, highlighted the survival benefit in the clinically relevant subgroup, that is, and to highlight again, the smokers had add-on advantage of receiving immunotherapy. So then if we talk about subsequent treatment, we see that patients with who received chemotherapy in the first line, most of them received immunotherapy in the subsequent lines. So having again reiterated that PD-L1 expressors, even if they don't receive the immuno in the first line, there is a scope in receiving the second line. So in the PD-L1 high expressors, if we see the median PFS, so median PFS was basically 12-month median PFS was 36.9 months in the atezo arm versus 21.6 in the chemo arm. So this graph again shows that there was a difference and good difference in overall response rate also in PD-L1 high expressors, again highlighting the role of immune single agent in PD-L1 expressors as compared to chemotherapy. So updated safety profile also shows that, I mean, the immuno is better tolerated than chemotherapy. So as we all know, and all the adverse effects, be it, I mean, the immune related side effects, they are well tolerated and well manageable as compared to the chemotherapy arm. So this again graph indicates that it was better tolerable and there was more than 5% difference in all cause adverse effects between the immuno versus the chemo arm. So to summarize, this study showed that atezo represents a promising first-line treatment option in PD-L1 high expressors non-small cell lung cancer. And it is a positive study that demonstrated statistically significant and clinically meaningful improvement in overall survival in PD-L1 high expressors versus the chemotherapy. So being impressive hazard ratio of 0.59. The safety profile, as we know, it was consistent with prior observations of all immunotherapy trials, and atezo did not pose any additional safety concern as per this trial. So now if we talk about IMpower 150, so it basically tried to look into the non-squamous histology, and it was a phase 3 study of atezolizumab plus chemo and Bev in first-line advanced non-small cell lung cancer. So if we see the main highlight of this study was that all subset, irrespective of the histology or irrespective of the driver mutation, were included. So, so that is one study which highlights that we can utilize this IO and Bev combination along with chemotherapy in driver mutation positive also. So this, though this was a subset analysis to be looked into. So this trial included all advanced non-small cell lung cancer which were chemotherapy naive, and these they were stratified also according to the PD-L1 IHC expression. And there were 3 arms of randomization. One was at atezo plus carbopectly, another was atezo Bev and carbopectly, and third was chemo and targeted therapy, that is Bev arm. And the drug was continued until of the progressive disease or the clinical benefit was there. So the rationale behind adding bevacizumab to atezolizumab is that, I mean, bevacizumab inhibits the VEGF-mediated suppression of dendritic cell maturation, and and thus it enables the efficient priming and activation of T cell responses. And chemotherapy backbone actually it induced the immunogenic cell death that can trigger the release of tumor antigens. So bevacizumab normalizes the tumor vasculature, resulting in an increased infiltration of T cells into the tumor, and this leads to the better efficacy for the immunotherapy to act on. So now if we see the baseline characteristics in this trial, so all the 3 arms were well matched and well balanced. They also included all groups, that is smoker or non-smoker, and the driver mutation, like I told, were also included, though the number was small. So there was what this trial showed, that there was a significant overall survival benefit with the addition of atezo to the control arm in the intention to treat analysis. So the experimental arm showed a 12-month overall survival of 67% as compared to 61% in the targeted and chemo arm, with the hazard ratio of 0.80. So median follow-up was 39.8 months. So overall response rate and duration of responses were also improved in the intention to treat analysis, and the combination of atezo Bev over the chemotherapy did fairly well. However, atezo and chemo arm was not a better, doer in this subset. So OS benefit was observed across all the PD-L1 subgroups in the intention to treat analysis, and as we saw in the previous slides also, that PD-L1 high expressor has derived the most benefit with the addition of atezolizumab in the control arm, in the experimental arm. So if we see, efficacy in other key subgroups, that is driver mutation positive, what after EGFR positive, after the EGFR TKIs are utilized. So we extrapolate IMpower study in this subset of population where the driver mutation was actually pre-treated, and they progressed on this EGFR, anti-EGFR therapy. So in intention to treat analysis, we saw that actually this is also a good option in those patients where we have exhausted or utilized the anti-EGFR therapy. And the clinically meaningful PFS benefit was observed as compared to the chemo and targeted arm in this subgroup. So there was also a quantum of overall survival benefit seen in patient with sensitizing EGFR mutation in the atezo, bev and chemo arm as compared to the bev and chemo alone. So overall response rate and duration of response rate were also improved in the immuno plus the control drugs, and overall response rate increased from 42% to 71% with the addition of atezolizumab to bev and chemotherapy. So if we see the patients who had extensive visceral disease, that is in the terms of liver metastasis, so this trial again showed that there was clinically meaningful PFS advantage in the intention to treat analysis in patients with liver metastasis at the baseline, and the addition of atezo actually improved the 6 months PFS in terms of 58% as compared to the 37% in the chemo and bevacizumab arm. And at 18 months also, this quantum of benefit was sustained with the atezo and bev arm doing 23.3% median PFS at 18 months as compared to 1.8% only in the chemo plus targeted arm. And patients with liver metastasis, they showed meaningful survival benefit with IMpower 150 regimen, despite liver metastases being a negative prognostic factor in non-small cell lung cancer. And again, highlighting the same thing, and overall survival benefit was also observed in this subset of patients, and with the impressive hazard ratio of 0.52, and median OS was 13.3 months as compared to 9.4 in the control arm. So, and if we see only atezo plus chemo arm, there was no benefit in terms of addition of only atezo to chemo arm in terms of liver metastasis subgroup. So addition of bevacizumab to atezo plus chemo improved overall response rate and duration of response in patient with liver metastasis. So if we see the patients who had actually the bulky disease, so this was an exploratory analysis from IMpower 150, which evaluated efficacy in arm B versus arm C using two different measure of bulky disease, that is high disease burden versus low disease burden. And if we see efficacy outcomes of high and low disease burdens were actually defined by the sum of the longest dimension and of the tumor and measurable tumor and number of the metastatic site. So if we see in patients with high tumor burden, that median overall survival was improved as compared to the arm C, that is the chemo and targeted alone arm, that is 15.5 months versus 10.7 months. And in the low tumor burden, so it was 20.3 months versus 17.1 months. So the clinical benefit from addition of atezolizumab to bev and chemotherapy was observed in patient with and without bulky disease. So irrespective of the disease burden, so this option fared well as compared to the control arm, and it was regardless of the approach used. So IMpower 150 actually concluded that it was more effective regimen when atezo bev was combinedly used with chemotherapy as compared to any agent alone. So it was also again well tolerated. As we know, both of the drugs have the manageable safety profile, and we are now used to managing those side effects which occur with this combination arm. So IMpower 150 also concluded that it is a good option in first line in non-squamous non-small cell lung cancer with statistically significant and clinically meaningful improvement in both co-primary endpoints of overall survival and PFS. And clinical benefit was observed in key subgroups of patients with EGFR ALK genomic alterations also. So a good option where we have exhausted our driver mutation options. And atezo in combination with chemotherapy plus bev is well tolerated, and it did not raise any safety concerns. So to summarize, IMpower 150, I mean, it was a phase 3 multi-center international randomized open label phase 3-arm trial. And it is the first chemo, immuno and targeted therapy combination to demonstrate meaningful overall survival in driver mutation patients also, and with heavy burden disease liver metastasis patients also. So it nearly doubled the PFS benefit at 12 months, with 12 months PFS of 38% in the experimental arm versus 20% in the control arm. So if we see IMpower 130, I mean, it tried to look the role of atezolizumab in basically the non-squamous non-small cell lung cancer. And it was basically a phase 3 study of carboplatin and nab-paclitaxel with or without atezolizumab in first-line advanced non-squamous non-small cell lung cancer. So the rationale for combining atezolizumab with chemotherapy, we know that atezo has the ability to restore anti-cancer immunity by preventing T-cell deactivation. Basically, immune checkpoint inhibitors work on this principle, and chemotherapy basically expresses the tumor antigens by causing the programmed cell death in the tumor cells, and which immunotherapy actually works on this principle of exposure of tumor antigens. So now IMpower 130 included the advanced non-small cell lung cancer who were chemotherapy naive and good performance status, and they were again re-stratified according to the PD-L1 expression and liver metastasis. So this trial actually tried to see the use of nab-paclitaxel, whether it provides an alternative potential steroid-sparing chemotherapy regimen. And the experimental arm contained the carbo and nab-pacli and the pemetrexed or best supportive care. So now the co-primary endpoint which was studied was PFS in intention to treat analysis, and secondary endpoints were investigator assessed PFS and OS in intention to treat analysis. So baseline characteristics were generally well matched in both of the arms. And as you can see, the investigator assessed PFS was significantly improved with addition of atezo to carbo and nab-pacli in the intention to treat analysis, with atezo and chemo arm having a 6 months PFS of 56.1% as compared to 42% in the chemotherapy arm. And there was a 12 months PFS benefit, which actually doubled with the addition of atezolizumab to the chemotherapy arm. So if we see the overall survival, it was also significantly improved with the addition of atezolizumab to the chemotherapy, with 1 year overall survival of 63.1% as compared to 55% in the chemo only arm. And the OS benefit was actually observed across all the clinically relevant subgroup, be it the liver metastasis, be it the smokers, be it the PD-L1 high or median expressors. So actually there was no PFS or OS benefit observed over chemotherapy alone in the driver mutation positive subgroup. We all know that the immunotherapy is not a good choice alone in this subgroup of patients. However, addition of BEV did add it to the advantage. So overall response rate and duration of response were also improved in the experimental arm as compared to the control arm, and a higher proportion of patients had a complete or partial response in the experimental arm as compared to the control arm. So atezolizumab and chemotherapy was well tolerated with a good safety profile consistent with the known side effects, and there was no additional safety concern. So this trial also concluded that IMpower 130 was a positive phase 3 study for atezo use in first-line non-small cell lung cancer, providing an alternative chemo, immuno, and targeted option over and above chemotherapy regimens for patients with chemotherapy naive advanced non-small cell lung cancer. And it demonstrated a statistically significant and clinically relevant overall survival benefit when atezo was added to carbo and nab-pacli despite the high crossover rate. Atezo plus chemo had a safety profile which was consistent with adverse effect associated with the addition of IO to the chemotherapy arm. So I thank you all for the patient listening.
So thank you very much, Dr. Shefali, for that excellent talk. You've covered most of the prominent trials with this drug atezolizumab in combination with chemotherapy in this large space of advanced non-small cell lung cancer. So thank you once again. And moving ahead, we have the next session, which is to be given by Dr. Piyush Bajpai. So he is the head of the department and consultant medical oncology at Manipal Hospitals in Delhi. And we want to understand his take on the role of atezolizumab in the management of first-line non-small cell lung cancer. So it may appear a similar topic, but it's a slightly more deeper dive into the data and understand a slightly different perspective of the data. So over to you, Dr. Piyush.
Yeah, thank you, Dr. Devrat. May I share my screen? Yeah. So, I would thank Dr. Devrat and Roche for actually providing this opportunity. And I find that there is a bit of overlap, rather quite an overlap on the previous topic what Dr. Shefali covered. So we can actually take some questions as well, hopefully, Dr. Devrat. So moving on these two particular studies, and this is what Dr. Shefali covered, that this is a chunk of what we see over here, which is actually, a challenge to treat without any targeted mutations. And this is this particular chunk was being dealt with chemotherapy, and now immunotherapy is an entrant over here. Well, chemotherapy has been there, but then there is something what you would want a chemotherapy-free sort of treatment, and this is what answer is being given by IMpower 110, and here atezolizumab monotherapy proved to be a better agent than chemotherapy in PD-L1 selected chemotherapy naive patients. And likewise, IMpower 130, which was a steroid-sparing chemotherapy regimen combination with this atezo. And here, again, the combination proved better than the chemotherapy alone. Talking about the IMpower 150, what Dr. Shefali covered, and this again, the quadruplet regimen over here actually proved better in a heavy burden disease, in liver metastatic disease. So this is the subset that you would want to treat if in case you are seeing. So this is important. Also, the EGFR mutation, pre-treated patients, so there were a few percentage of them included. So coming back to IMpower 110, which was actually including the squamous and non-squamous histologies, where the platinum agent was cisplatin or carboplatin and pemetrexed or gemcitabine in first-line NSCLC. This was allowed. Well, it was randomized, against atezolizumab, and that's 1200 mg at every 3 weekly. And so here there was a PD-L1 selection, and it was largely a EGFR negative population. And the PD-L1 IHC expression, there was a stratification, rather a selection, and the therapy was given till progressive disease or loss of clinical benefit, with a primary endpoint of overall survival in wild type population. And key secondary endpoints were PFS, overall response rate, duration of response. And this was a hierarchical statistical testing plan, where you would see the testing was done with overall survival in the TC3 or IC3 patients, where alpha was set as 0.0413. And the primary endpoint of overall survival was tested hierarchically. If it was found positive, then TC3 and IC3 wild type, then one would go and see the TC2 and 3 or IC2 and 3, or otherwise TC1, 2, and 3 and IC1, 2, and 3. So the secondary endpoint of PFS will be formally tested only when the primary endpoint is positive among all three populations. So what we see, and this is what we tend to see, is almost nearly a third of patients have this sort of profile. They would be high, having a high PD-L1 expression either on the tumor cell or on the immune cell. So what was the cutoff point was more than 50% of expression on the tumor cell or more than 10% on the immune cell. And if you look at the age profile, it was largely less than 65 in both the arms. There was more of a male population, and then there was more of a smoker population. So never used tobacco was just nearly a single digit in across the board. And then non-squamous histology was nearly 70% in both the arms, and a good performance status. So this is what we saw, that overall survival was reached, and the median overall survival was improved by nearly 7 months with atezo over chemotherapy. And this was a 6-month overall survival of 76 versus 70 and 64.9 versus 50.6%. So there was this incremental jump and statistically significant overall survival. If we look at the subgroup analysis, the forest plot, we find that all of them are benefiting, but if you see that never used tobacco probably lagging behind slightly. The elderly, very few numbers over there, but then the younger population getting more benefit. So definitely most of the subgroups were getting the benefit. Even the squamous was getting a benefit over there. So looking at longer follow-up, continued overall survival was observed in the atezo arm. And at updated exploratory overall survival analysis in high PD-L1 expression, continued overall survival improvement was observed in atezo versus chemotherapy arm. So talking about subsequent cancer therapies, well, in the chemo arm, nearly 1/3 of patients, 35% of patients subsequently received chemoimmunotherapy. So a good proportion receiving this chemotherapy, but then again, the overall survival was maintained. So a good crossover happening, but the OS did not budge. So talking about the TC2 and 3, basically this was the overall survival was not statistically significant, but numerically it was better. So this was not a formal analysis which was done. And likewise, the overall survival, there was a numerical improvement in the TC1, 2, and 3, or IC1, 2, and 3. So there was a numerical significance, but then not statistically significant. And therefore, the PFS was not formally tested due to the hierarchical testing plan. But it was, if we look at it, it was clinically meaningful, PFS of 8.1 months versus PFS of 5 months. And if you look at the TC3 or IC3 updated analysis, where they continue to be a clinically meaningful PFS improvement, so this was definitely a good improvement in PFS. Again, not formally tested. And we look at the overall response rate, it was nearly 38% in the atezo arm versus 28.6% in the chemotherapy arm. So yeah. So talking about the overall survival benefit in the PD-L1 high subgroup for atezo over chemotherapy was maintained with whether you check your PD-L1 by SP142 or by 22C3 method or by SP263. If in case you are falling on the higher side of the getting the PD-L1 on the higher side, you would derive the benefit with atezolizumab monotherapy. So at the primary analysis, atezo demonstrated a favorable safety profile compared to chemotherapy, and the safety profile was consistent with the known previous safety profile. No new unexpected safety signals were identified. So the most common all-cause adverse effects are typically associated with chemotherapy, and very less side effects, significant immune side effects with atezo were seen. So that brings atezo in the category 1 indication in NCCN as a monotherapy if we have a high PDL1. And likewise also in the ESMO clinical practice guidelines. So to summarize, atezo represents a promising first-line treatment option in patients with high PDL1 NSCLC, and it's a positive study that demonstrated statistically significant and clinically meaningful OS in the TC3 or IC3 population versus platinum-based chemotherapy. The safety profile of atezo was consistent with the prior observations. No new unexpected safety signals were identified. Immune-mediated adverse effects were generally low grade. And atezo had a favorable safety profile compared with chemotherapy, and the safety data were consistent with those from pooled atezo monotherapy population. Talking about the other trial, IMpower 130, the phase 3 study of carboplatin and nab-paclitaxel with or without atezo in first-line advanced non-squamous NSCLC. Again, atezo has the ability to restore anti-cancer immunity by preventing T-cell deactivation, and chemotherapy induces immunogenic cell death and can trigger the release of tumor antigen. And therefore, a combination can maximize the potential of the immune system and eliminate malignancy. This is the hypothesis, and IMpower 130 was designed all comers on PDL1 IHC expression over there, and liver metastasis also included. So this was pitched against chemotherapy. This was a steroid-sparing agent, as we can see nab-paclitaxel over there. That's important. And this was given 4 to 6 cycles, followed by maintenance of atezo. And the nab-paclitaxel dose at 100 mg per meter square of day 1, 8, and 15, 3 weekly, and carboplatin at AUC 6, 3 weekly. So there was a crossover, though the crossover was limited as per the June 2016 protocol amendment, but nearly 41% patients did crossover, and a total of 59% patients in the control arm received subsequent chemoimmunotherapy. So primary endpoint was investigator assessed PFS in intention to treat population, overall survival in intention to treat population, with secondary endpoint being investigation assessed PFS and overall survival, and investigator assessed PFS and overall survival in PDL1 selected population. So quite similar subgroups in both the arms. And what was seen was investigator assessed PFS was significantly improved with the addition of atezo and atezo-2, steroid sparing chemotherapy agent doublet, nab-paclitaxel and carboplatin. So it was a landmark 12-month PFS, which was doubled actually with the addition of atezolizumab when it was added to this combination. So overall survival was significantly improved again over here, and it was seen that it was nearly 63.1% at 1 year and 39.6% at 2 years, versus when we saw the chemotherapy, it was 55.5% and 30%. So there was a significant improvement. Most of the subgroups benefited again over here. What was seen was the EGFR ALK positive patients are not benefiting, and that's what we are practicing not to include. With this sort of combination, you need bevacizumab probably for EGFR specifically, and overall response rates and duration of response did improve in arm A versus arm B. And there were higher proportions of treatment-related grade 3 to 5 adverse events. The adverse events of special interest in the atezo chemotherapy arm, which was expected due to the additive effects of 3 drugs instead of 2. So the key conclusions were that it was IMpower 130 was a positive phase 3 study, and this provides an alternative chemotherapy plus immunotherapy regimen for patients with the chemotherapy naive NSCLC. IMpower 130 demonstrated statistically significant, clinically relevant overall survival benefit when atezo was added to carbo-nab-paclitaxel despite high crossover rate. And it demonstrated a PFS benefit and a high overall response rate when atezo was added to carboplatin and nab-paclitaxel. Overall OS and PFS benefit was observed across key clinical subgroups, except in the mutation-positive group and patients with liver metastasis and supporting use of IMpower 150 regimen. So if this is the subset, you need to add BEV over here also. Atezo plus chemotherapy had a safety profile consistent with adverse events associated with single agent therapy. No new safety signals were observed. So I think so, in case there are questions, if time permits. I hand back to Dr. Dev.
Yep. So thank you, Dr. Piyush. I think excellent take. I think that seems to be working in the poor prognosis subset, including those patients who have liver metastasis. In fact, the atezo trial is the only trial which has looked at patients who harbored EGFR or ALK mutation after they had used their standard EGFR or ALK TKIs. It's the only trial which has shown some benefit with the addition of atezolizumab along with bevacizumab with chemotherapy in this subset of patients. So thank you very much for your talk and the conclusions. And we move on to the last session of the day. And for that, I invite Dr. Atul Sharma, who's a consultant medical oncologist at JP Hospital, Noida. And he's going to talk about small cell lung cancer and applying the latest developments in practice. So over to you, Dr. Atul Sharma.
Thank you, sir. Is my screen visible?
Yes, Dr. Atul.
Yes, sir, it's visible.
So I think it's 8:45. So I will try to finish as early as possible. So as all of us know about the small cell carcinoma lung, it is a very aggressive neoplasm, and we have almost standard of drugs available in the first line therapy, but we have hardly any effective second line therapy, second line drugs. So this usually presents with a lot of symptoms, weight loss and fatigue. Most of the patients with small cell carcinoma lung, they are smokers, and we hardly have any targeted therapies against them. So out of total lung cancers, almost 10 to 15% they constitute small cell lung cancer, and the non-small cell adenoma being the most common. So you usually divide small cell carcinoma lung into the limited stage and the extensive stage, where limited stage we can address in one single beam of external radiation. And in small cell lung cancer also, most of the patients, they present with advanced stage, that is almost two-thirds of the patients. So scenario is same in India as compared to the other countries. So this is a schema where we can see the treatment algorithm. In limited stage, we most likely would do CT-RT followed by prophylactic cranial irradiation. And in few cases in early stage where we do not know, maybe they undergo surgery when the nodal involvement is not there. In extensive stage, the platinum-based chemotherapy is the backbone, where cisplatin or carboplatin along with etoposide is the standard of care. Almost everybody uses this only. So there are certain drugs which are active, such as irinotecan, topotecan, and we use these drugs in subsequent lines as well. And in India also, this is the same practices, same almost 2/3 patients presenting in advanced stage. And so 5-year overall survival rates are very poor, as we can say. I mean, we are performing poor as compared to the Western world, where hardly under 3%, 2 to 3% are the 5-year survival rates in our country, and 6% around 2-year survival rate. Even over the years, there is not much significant improvement in the overall 5-year overall survival. We can see hardly it's around 2.7% improvement in 5-year survival from 1999 to 2008. So this is a unique disease where we have, I mean, the response, if we see the response rates, they are around 68 to 84%. But somehow we are not able to translate these response rates into a longer median progression-free survival and overall survival. So that's where we perform poor in the long-term survival. So there has been many agents. So this remains the standard of care from past 20 years. So many new agents being tested. So predominantly these are immunotherapy. They're trying and testing the immunotherapy in lung cancer. So many drugs such as ipilimumab, nivo-ipi combination, atezolizumab, pembrolizumab, all being added to the chemotherapy backbone. So this is the potential that we want to convert the high response rate into longer survival with the use of immunotherapy. And this is the mechanism which I think previous speakers have already discussed in detail, that what is the rationale behind combining chemo with the immunotherapy. So as other IMpower studies, so this is IMpower 133, where they combined atezolizumab with the carboplatin etoposide combination. So patients were randomized to the standard chemotherapy along with atezolizumab, which was given as 1200 milligram every 3 weekly. And 4 cycles of chemotherapy were given, which were followed by maintenance atezolizumab. So they considered for prophylactic cranial irradiation in those patients who were responding, but they deferred any use of radiation to the primary lung mass. So the recommended dosages, I think almost everybody knows. This is the trial which showing that additional 2 cycles may not give much benefit. So there were co-primary endpoints, OFS, or PFS and overall survival, and duration of response and overall response rate, along with the safety profile. So both the arms were reasonably well matched. And here we can see that there is almost 13% overall survival benefit at 12 months, which was statistically significant. I don't know how clinically meaningful it is, but there is 2 months survival benefit at 12 months. Median overall survival improved by 2 months. Again, there was improvement in 6 months PFS as well as in 12 months PFS also. Again, there is not much difference in the response rate with the addition of atezolizumab, and a marginal improvement in the PFS and OS, though it was statistically significant. If we see subgroups, so almost all subgroups were responding. So as I discussed the schema, the 4 doses of carboplatin etoposide were given in both the arms along with atezolizumab in the trial arm, and almost 67% response rate and 38%. These are the treatment-related adverse effects, almost similar. There were no new safety concerns. And the median PFS, it almost improved by a month, and OS improved by 2 months. And the 12-month overall survival improved by almost 13%. So these other guidelines, NCCN and European guidelines, they also recommend the use of addition of atezolizumab along with the chemotherapy arm. Both brain metastasis patients, they were also included, symptomatic and asymptomatic. Symptomatic, they were enrolled after giving the radiation to the brain. So in summary, this was one of the first trials showing that the addition of immunotherapy adds benefit to the chemotherapy in the small cell carcinoma lung. And this is this is one study where we can say though the number is small, but there is something which can add to the survival. I thank you everybody. In case somebody has some specific question, we can address that.
Thank you, Dr. Atul, for that excellent talk.
I think his screen got hanged. Doctor, yeah. Dr.
Okay.
Atul, sir, can you stop sharing the screen, please? Or you still have some slides?
No, my slides are finished. I'm trying to.
Just stop sharing the screen. That's it.
Sir, stop share. And do share screen by click on screen and share, sir.
Just a minute. I'm not able to. Let me.
Sir, you must be viewing something, the view options. You just have to click on the top of this view option, and then you can say stop sharing.
Yes, sir. Sir, may I stop share from my side?
Yes, yes.
Yeah,
Now I got
I
it.
done from my side. Yeah, now click on share screen button, sir. Green click button.
So I think we've had a very productive meeting. We wanted to talk about how there are newer paradigms in the management and treatment of lung cancer. I think in this session today, we have begun with an overview of the importance of molecular biomarker testing in lung cancer. And then we've had an excellent panel discussion on the current management of EGFR mutated patients harboring a non-small cell lung cancer, where Dr. Venkat did an excellent job taking inputs from medical oncologists from all over the country and how practices have been across different cities. We've talked about Ceretirib in the ALK rearranged non-small cell lung cancer space and how it retains a value as a frontline treatment option for these patients with ALK rearranged non-small cell lung cancer. We have looked at how Capmatinib has brought about answers to this unmet need in patients harboring a MET exon 14 skipping mutation. And then thereafter, we had Dr. Shefali Sardana talking about atezolizumab in the first-line treatment for metastatic non-small cell lung cancer. We heard Dr. Piyush Bajpayee give his inputs and his perspective, particularly particular focus on the IMPAR 110 and 130 studies. And lastly, we've looked at how immunotherapy has begun to add to improving outcomes in advanced small cell lung cancer. So with that, we come to the end of this meeting, and I thank you all for joining. I thank the sponsors, AstraZeneca. I thank Novartis. I thank Roche. I thank all the audience, and I also thank the digital team of Horizon Conferences for managing this meeting. Thank you very much.
So thank you so much, Dr. Devrat sir, for conducting such a wonderful meeting. Thank you. Have a nice weekend and goodbye from all of us. Thank you so very much.
Bye-bye.
And of course, thanks to my colleague Geetika for organizing this entire event. Thank you so much. Thank you, Geetika. Thanks.
Thank you,
Thanks,
sir.
sir. Thank you so much.
Thank you. Thank you.